بسم الله الرحمن الرحيم. أبنائي الأعزاء، الأول عايز أقول لكم كل سنة وأنتم طيبين، وعايز أقول لكم حاجة تانية، إن إحنا اللي اتحرمنا منكم، وأرجو إن شاء الله إنه ربنا يعدي الأزمة دي على خير ونلتقي تاني. وعايزكم تاخدوا الأمور ببساطة. العلم موجود ومتوفر في الكتب، وإحنا افيلابل باستمرار معاكم في الجامعة، وفي حتى لو اتصالات شخصية للإجابة على أي أسئلة. موضوعنا النهاردة هيكون عن الابيديميولوجي اوف كانسر سيرفكس. أنا عايز أقول لكم بس إن أنا لابس الماسك لأن ده الأونلي بروتكشن الافيلابل أو البروفد لغاية دلوقتي، فمن فضلكم يا ريت نلتزم، لأن واضح إن الأبحاث العلمية في الكورونا كترت قوي وحاجات بتكذب حاجة وكده، إنما الثابت الوحيد لغاية دلوقتي إن إحنا كل ما كنا بعيد عن مصدر العدوى كل ما ربنا حفظنا إن شاء الله. أنا هقلع بس الماسك عشان نبدأ المحاضرة. Our subject today is about cancer cervix. And when we are talking about any disease, we are looking for three main objects: if it is common or not, if it is serious or not, if it is preventable and has treatment or not. For this reason, cancer cervix is one of the very important cancers. If we look for its prevalence, it is the second most common cancer affecting women. It is after cancer breast. It is the second most common cause of cancer mortality in women. So it is common. At the same time, it is one of the preventable diseases. How? It has a long natural history, and the screening programs which are currently available all over the world and allows early detection and the treatment of pre-invasive lesions. The risk factors for cervical cancer are many, and we all know that we have some risk factors known for all malignancies, including age, and the age for cancer cervix is above 45. Smoking is one of the risk factors. Multiparity is one of the risk factors. Trauma affecting the cervix of frequent parity and frequent infections also is a risk factor. However, most important is immunocompromised women, those, for example, who has AIDS or have any renal transplant or something like that, are more prone to develop cervical cancer, especially if they are subjected to multiple frequent sexual partners. If they started to practice sexual intercourse early, younghood, before the age of 16 or 12, before the age of 16, again, if they have early parity or early deliveries. These are the risk factors. However, the only one documented, proved pre-cancerous infection is the human papilloma virus. Is one of the sexual transmitted diseases. Fortunately, it is transient, it is self-limited disease, and it may be asymptomatic. However, human papilloma virus, when it affects any female, it has a risk of developing the cervical cancer about 35% of the cases. And it was present in 99.7% of cervical cancers. So please, usually check and be sure that the main risk factor for cervical cancer, in addition to the other mentioned factors, is human papilloma virus infection. Regarding the pathogenesis, as we know, the cervical cancer is well known to start affection in the transformation zone. What is the transformation zone? The transformation zone is the area between columnar epithelium affecting the endocervical canal and stratified squamous epithelium lining the vagina. The columnar epithelium in pregnancy, the columnar epithelium covers the endocervix as well as the upper two-thirds of the vagina. But after childbirth, and with early pregnancy, there is transformation or metaplasia of the columnar epithelium into stratified squamous epithelium. That means that the columnar epithelium is taken up and being replaced by the stratified squamous epithelium. This area between the original or the native squamocolumnar junction and the new squamocolumnar junction is called the transformation zone, which is the site of frequent maturation, growth in early childhood and later on. And at this area, any carcinogen can affect the transformation zone and start the pathogenesis of cervical cancer. As we know that there is physiological metaplasia that occurs in the transformation zone where the squamous epithelium replaces the columnar epithelium and is more active at puberty, while the pathological metaplasia is that columnar epithelium is changed to dysplastic cells, and this can progress to in situ or cervical intraepithelial neoplasia, and lastly it will progress to cancer. Fortunately also, some of the cases can regress back to normal. Risk factors increase the propensity for developing cancer, especially immuno. Before going to the cervical cancer, we have to know what's cervical intraepithelial neoplasia. We have two terms to know: the dyskaryosis and the dysplasia. Dyskaryosis means the changes in the shape of the cells. In the cell itself, it's a cytological term, which means changes in the cytology, in the cell structure, in the form of increased nuclear cytoplasmic ratio, abnormal mitotic figures, hyperchromasia, multiple mitosis, and something like that. For CIN to develop, we have certain abnormal changes in the cervical epithelial growth and polarity, which stops short of malignancy. Yani, to say cervical intraepithelial neoplasia, there is some architectural and cytological changes which stop short of malignancy, yani just before malignancy. If the abnormalities affect the basal layer, the basal third, the lower third only, it is CIN1 and it's usually mild form. If it affects the middle, the lower and the middle third, or the lower two-thirds of the epithelium, it is moderate, in which we call CIN2. CIN3, or the severe form, the abnormal cells affects the whole layers, but with preservation of some of the superficial cells. If the whole thickness, including the superficial cells, is affected by these malignant changes, it is called cervical carcinoma in situ. Whole epithelial thickness is replaced by abnormal cells. The differentiation is made on cytological basis, and on cytological basis we have the clinical picture first before diagnosis. Any patient with cervical intraepithelial neoplasia or carcinoma in situ or even frank cancer may complain of vaginal bleeding as the most common cause, especially postcoital or post-contact, even after examination. You may find no bleeding, but there is blood-stained, full-smelling, offensive discharge, together with other signs of malignancy, including weight loss or obstructive uropathy and cachexia. The gross picture: the commonest form of cancer cervix is the cauliflower exophytic growth. It is, as you know, that cancer is affixed, friable, penetrable, indurated. It may be in the form of an ulcer with the typical malignant characters being hard base, everted raised edges, necrotic floor, and bleeds to touch. Sometimes it may appear as only flat indurated area. The microscopic picture of cancer cervix Usually the commonest form is 80% of the squamous cell carcinoma, where it represents around more than 80%. This squamous cell carcinoma may be large cell keratinizing, or large cell non-keratinizing, or small cell non-keratinizing. The large cell non-keratinizing is the commonest, around 65%, and is the best prognosis. The small cell non-keratinizing is the rarest, around 5%, and carries the poorest prognosis. You may have verrucous carcinoma, sometimes papillary or transitional, but all are epithelial. Sometimes it may be an adenocarcinoma, which is rare. The incidence is around 18 to 20%, and may be more in older patients. 80% of cervical adenocarcinomas are made of cells of the endocervical type. When we make adenocarcinoma, it is endocervical mucus secreting cells. The remaining tumors, as you know, are populated by endometrioid, clear cells, interstitial cells, mixture of more than one cell, as any cancer anywhere in the body. But the commonest is stratified squamous. This is a picture, gross picture of cancer cervix cauliflower mass projecting through, filling the vagina and projecting out through the vulva. How to diagnose cancer cervix? To diagnose cancer cervix, we have to look for the very common and very simple test. It is pap smearing. George Papanicolaou is an old scientist or physician. Since 1920s to 1940s, he proposed this test. Actually, this test is very feasible. This is the instruments which we use. This is called Ayer's spatula. As you show this open end, we put this around the ectocervix and rotate it through 180 degrees to scrape part of the endocervix as part of the ectocervix as the vaginal epithelium in the upper fornices. This is the site of brush where we can brush the endocervix. When we get cells for examination, we make the swab or the smear by the pap smear kit. We spread it directly on a slide and fix it immediately before drying. And we are looking for the shape of the cell. In this karyosis, as we mentioned, it is a cytologic term. We have the mild form. The mild form here, we have the superficial cells, which are normal cells with normal sized nuclei and nuclear cytoplasmic ratio, and with angular border. This is the normal cell with very, very mild or no changes in the cytologic picture. We call it mild. In the moderate dyskaryosis, this affects mainly the intermediate cells with the increased nuclear cytoplasmic ratio compared to the first one, that the nucleus is less than 50% of the cell size. With severe forms of dyskaryosis, this mainly in the parabasal cells, affecting the whole layers usually, or the whole film. The nucleus is more than 50% of the cell size. The cell boundaries are not angular as this one, but as you see, and the nuclear cytoplasmic ratio, you may find some nuclear irregularities زي الهايبركروميزيا بقية السلايد مش باينة تحت. This is the cytologic diagnosis on the smear. We are looking for cells, but CIN to be properly diagnosed, and the cancer cervix, we are looking for histology, sections or specimens from the whole thickness, and to be examined after staining. CIN1, or the first one, when the upper two thirds of the epithelium looks normal, with mild nuclear abnormalities affecting only the lower layer. To this, the upper two thirds mostly looks normal. The affection or the nuclear abnormalities are mainly in the lower third. With CIN2, we find that the upper cell, almost half of the field, is this is poorly differentiated or undifferentiated or shows some nuclear abnormalities, and the affection keeps the upper third almost normal. Here you look, you will find more pigmentation of the hyperchromasia of the nuclei, and with more magnification you can see. With CIN3 we find the whole thickness of the epithelium from the basement membrane to the surface epithelium affected with dyskaryotic changes or with abnormal nuclear cytoplasmic ratio, abnormal mitotic figures, hyperchromasia, and this, but with preservation of few of the flat squames on the surface. For this, it is still cervical intraepithelial neoplasia. السلايد عايزة تتحرك تنزل تحت. We have to look for the pap smear, as we say, how to take it, but we should know that more than 20% of cases show false negative results, and we are not usually should dependent, but is mainly for screening. It is used all over the world as a routine for women above 40 to make this pap smear, and if there is suspicious smear. The interpretation of the pap smear, we usually have 5 degrees. Please fix it. It's not in the slide, but I'll tell you. The first degree is normal, when you find normal cells. The second degree of pap smear is abnormal, but due to inflammatory changes, not malignant changes. This is the first and second degree. The fifth degree is frank malignant. You saw all the typical malignant criteria. The fourth is this suspicious for malignancy, and the third is midway, in where there is abnormal cells but not malignant. Okay? So pap smear, this is old nomenclature, is normal, or there is abnormal but with due to inflammatory reaction. The third and the fourth are abnormal with mild to severe pre-malignant changes or malignant changes, and the fifth is the frank malignancy. This is a pap smear, and actually it has a very good rule in reducing the incidence of cancer cervix all over the world, especially in those who make it as a routine. The second screening and diagnostic test is the colposcopy, and the colposcopy is a microscope which can be focused on the cervix, that give magnification up to, from 10 to 40. When you have abnormal cytology, or you are not sure of your cytology report, then colposcopic examination is important, as it suggests there is some important. How to examine by the colposcope? We first put acetic acid, this acetic acid called cleans the area of abnormal mucus or shreds, and clear you may find some abnormalities. Another test is to look for the blood vessels. When you find abnormal blood vessels, or in the form of coma-shaped vessels in particular, or abnormal branching, you are in doubt for possible malignancy, suggesting invasion. If we find abnormal blood vessels, if we find irregular surface contour of the epithelium, or changes in the color tone. What is the importance of this colposcopic examination? You are looking for the cervix, and you should check for the transformation zone. If you can't see the transformation zone, then the colposcopy will be inadequate. If you can't see the limits or the margins of the lesion, if you can see a lesion but you can't see its margins, the colposcopy is inadequate. Colposcopy is indicated when you are in doubt, when there is suspicious cytologic findings. The importance of colposcopy is not only to raise suspicion or to predict or for screening, but to direct biopsy. You are seeing a lesion, and you have to take biopsy from this lesion under colposcopic guidance. This is a picture showing the colposcope like any magnifying microscope. This is some of the abnormal pictures. Abnormal picture on colposcopy, what we call mosaicism. You look for the different sizes of the lining epithelium because it magnifies it. Here is abnormal vessels with punctation. You see these multiple spots with dark spots indicating the head of comma-shaped blood vessels. And it also indicates when we see this mosaicism, this punctation, sometimes it's, as we see before, it gives an idea about the pattern, the vascular pattern, which also give rise to suspicion. This is another instrument where we can take some biopsy by the loop or diathermy to ablate some lesions with a probe with a wire that can be heated electrical biothermy, and this heat will destroy or cut through the cervical tissue. The colposcopic findings which give suspicions, as we say, abnormal blood vessels which may be looped blood vessels, branched vessels, reticular vessels, bezier-shaped and comma-shaped vessels. These are the most common colposcopic findings that suggest cancer. Punctation and mosaicism, which we referred to in the previous slide, are the classical pattern in cervical intraepithelial neoplasia. يبقى أنا لو شفت البانكتيشن ده فين البتاع مش شغال لايتلي البانكتيشن ده أو الموسايسيزم, these are the most suggestive picture for cervical intraepithelial neoplasia. This is also another form of abnormal blood vessels. Other more sophisticated we are not looking for. Then last diagnostic and the most sure is the biopsy. Usually you have a biopsy, examine under anesthesia. This is the punch biopsy forceps. We usually take multiple punches from the cervix, especially in the affected area. Better to be directed under colposcopy to examine. What is the histological appearance of invasion? We are looking for the basement membrane. If it is intact, we say there is no invasion. But after histological examination, we can check how much is the invasion, and usually in staging, inshallah, now we will know that if there is micro-invasion or minimal invasion 3 millimeters, there is microscopic invasion from 3 to 5 millimeters, and there is the gross invasion more than 5 millimeter, which are important for staging of cervical cancer. This is a form of invasive cancer showing that the whole area of the whole thickness is involved, and even the basement membrane is infiltrated. Another picture for invasive cancer. This is the gross picture of a uterus removed by radical hysterectomy. This is the uterus. Usually we are removing the fallopian tube. This is around because this is anterior picture with the ovaries and fallopian tubes on either side. This is the parametrial lymph nodes up to the lateral pelvic lymph nodes on this side. This is the cervix, should be cut complete, and this is the cuff of the vagina. These are the things which are removed in what we call per times radical hysterectomy. How cancer cervix spread? Number one, the direct invasion, and direct invasion first from the cervical mucosa to the stroma, then up to the corpus, down to the vagina, lateral to the parametrium. Second is lymphatic spread to the paracervical lymph nodes, parametrial lymph nodes, then more lateral to the obturator and external iliac, then more lateral and more up to the common iliac, and lastly to the paraortic lymph nodes. Blood-borne metastasis rare, and the intraperitoneal spread. So the spread direct, as we know, the forward to the bladder, posterior to the rectum, uterosacral ligaments, upward to the uterus, downward to the vagina, lateral to the parametrium. When it extends laterally to the parametrium, it just compressed the ureter and leading to hydroureter hydronephrosis, ultimately uremia, which is the commonest cause of death in cancer cervix. So direct spread is very important as it can lead to renal failure and death. The lymphatic spread, the first relate in the paracervical and ureteric lymph nodes, intermediate relate to the obturator lymph nodes and external iliac groups, medial or anterior groups, and as well as lastly to the common iliac and up to the para-aortic lymph nodes. So blood-borne, as you know, any other carcinoma to the blood-borne brain, liver, and lungs. Very rare surface is spread during operation. This is a contribution or the picture of the pelvic lymph nodes, the uterus, here the cervix. This is the parametrial lymph nodes, first and second groups, and paracervical. This is the obturator and external iliac group, obturator group, the internal iliac, the common iliac, and lastly to the para-aortic lymph nodes. After spread, we are looking for staging. Cancer cervix is the only genital malignancy which can't be surgical staging. It is clinical staging. Cancer cervix is a clinical staging, and through clinical examination. First we look for by inspection to the cervix, then by BVs, and by BR under anesthesia, and to examine up to the parametrium and pelvic lymph nodes. These are the stages we'll enumerate later. The FIGO staging. برضو الصورة دي يا محمد مفروض انها تعلى شوية. This stage 1 cancer where the lesion is confined to the cervix. Sometimes it is endocervical. This is on the ectocervix. This is endocervical, making a barrel-shaped cervix. This is stage 1. Also, this is the exophatic or the cauliflower projection. Then this is stage 2, where the cancer starts to spread to the upper part or the upper third of the vagina. This stage 2B with extension upper vagina here and lateral parametrium, but not to the lateral pelvic walls. If it extends to involve the parametrium up to the lateral pelvic wall or down to the lower third of the vagina, it is stage 3 cancer cervix. Again, stage 3 with extension into the lateral pelvic wall, infiltration of the parametrium. The vagina isn't involved. Here another picture with stage 3 infiltration of the parametrium as far as the lateral pelvic wall. This is a picture when the cancer, this is the cervix here. Anteriorly, this is the bladder and well infiltrated, bladder mucosa. Posteriorly, the rectum and infiltrating. This is stage 4 with invasion of the rectal and the bladder mucosa. Actually, if there is bone metastasis, if there is distant metastasis in the lungs or elsewhere. This is another gross picture for the cancer cervix. If it is still localized to the cervix here, it is stage 1. If it extends to the upper vagina, only stage 2A. If it extends to the parametrium, but not to the lateral pelvic wall, it is stage 2 here. If it extends more to involve this pelvic wall, it is stage 3. If it involves the bladder anterior or the rectum posterior, it is stage 4. So staging procedure is a clinical procedure through examination of the vagina, the cervix, and by manual and BR examination under anesthesia, and try to feel pelvic lymph nodes if possible. Then for staging, most important is radiologic studies for distant metastasis, intravenous pyelography, barium intravenous pyelography for the urinary tract, barium enema for the lower GIT, chest X-ray for the chest, MRI and skeletal X-ray for the spine and pelvis. When abnormalities are noted on CT, MRI, or PET scanning, radiographic guided needle aspiration can be performed from these metastatic sites, and individual treatment should be planned on that. This is staging of the cancer cervix. The treatment options, usually we are looking, when we are treating a case, we are looking for, number one, what is the definitive diagnosis? If it is cervical intraepithelial neoplasia, if it is cancer inside, or if it is actual invasive cancer. And we have many options depending on the patient's age, the patient's general condition, the family size, and if the patient has completed her reproductive goals or still needing more children. We have the most common and the most effective rule is surgery, and surgery has a wide range of options, starting from conizations, that we are removing a cone of the cervix, and we'll go to tell about, or simple hysterectomy, we are removing the uterus only, or radical trachelectomy, we are removing the cervix only with the lymph nodes, or radical hysterectomy is the first time which we showed the specimen before, where the uterus, the tubes, ovaries, parametrium, lymph nodes, and cuff of the vagina. Shout is another form of radical operation done vaginally. Pelvic excentuation for advanced cases involving the bladder or rectum. And lastly, external teletherapy, internal therapy. This is radiotherapy after surgical treatment. What are the advantages of surgery? Some tumors are radio-resistant. Without radiation, it will not be effective. And some cases recur after radiotherapy. And if complications of radiotherapy are done. The complications which are afraid of, there's bladder dysfunction, because you are not only removing the pelvic nodes and tissues and parametrium, but we are disturbing or interrupting the nerve supply of the bladder and the ureter. Injury will involve the ureter with the formation of ureteric fistula. Usually with pelvic manipulations and prolonged time, the patient is more susceptible to DVT and pulmonary embolism. Lastly, lymphedema of the lower limbs, because after pelvic lymphadenectomy. Treatment stage by stage. Look here, stage 1, and we have 1A1 and 1A2. 1A1, when the tumor is confined to the cervix, is localized with minimal or micro or minimal invasion less than 3 millimeter. Then we can do conization, remove the cone of the cervix with the lesion. Sometimes you have to do total abdominal hysterectomy if the patient completes her family size. 1A2, that's the extension or the infiltration exceeds 3 millimeters to 5, then we have to do the radical surgery for times operation. If the patient stage 1B, then Vertime operation followed by radiotherapy or radiotherapy alone according to the patient's condition. Stage 2A is the last stage for surgical intervention. We can do Vertime's operation. More than stage 2A, stage 2B, or stage 3 or above, we are not going for surgical intervention as the parametrium is infiltrated and you will do more harm than benefit, so we start by the radiotherapy alone. For stage 4, according to the area involved, we are looking. Radiotherapy, and this radiotherapy are indicated when surgery is contraindicated, mainly cases after 2B and cases who are not generally fit for surgery, and where all stages, especially in advanced one, we look for the radiotherapy. Many tumors are radio-resistant, and there is a possibility of recurrence if the patient is pregnant and cannot, or there is any infection or associated pathology. Radiation is not possible. Last option is the chemotherapy, and it is indicated in association with radiation, what we call chemoradiation. And it is mainly for palliation of progressive cancer and release of patient pain and symptoms. Many agents are known, the methotrexate, bleomycin, and cisplatin. Again, this is a staging, and we can manage this according, but the previously summarized is best. Stage 1A, 1A2, or 1B1, or 1B2, according to the lesion. We may do either radical trachelectomy, stage 1A and 2, A1A and 1, 2, or modified radical hysterectomy with pelvic lymph node dissection. 1B, radical hysterectomy with pelvic lymphadenectomy. 1B with more 5 millimeter invasion, type 3 radical hysterectomy with pelvic lymphadenectomy and or radiotherapy. This is the policy for treating of cancer cervix. We can do combination regimens according to the severity of the case, but it is beyond your scope. Before finishing, we have to say that prognosis for cancer cervix depends on FIGO staging, the 5-year survival rate. For example, in stage 1, the survival, 5-year survival is more than 90%. Stage 2A, which is still surgical, we have the survival more than 80%. Stage 3A, about 45%. B, 35%. Stage 4, less than 15%. Actually, any tumor. For this case, we say that cancer cervix is, we have to take home message that cancer cervix is preventable disease. It is easily diagnosed. It can be screened and diagnosed early. For this reason, the prognosis is much more better. And thank you and good luck.